All right, so this is going to be part one lecture video for the Pharmacology chapter 9, which is respiratory drugs. So this chapter is not only going to cover drugs that are used for respiratory diseases and disorders, but also gives you an idea of what those different diseases and disorders are. So the first thing up here on slide 5 is asthma. So asthma is a chronic inflammatory disorder of the airways. It causes coughing, wheezing, breathlessness, and even chest tightness. Characteristics is it is a reversible small airway obstruction. So the swelling or inflammation within the airways is causing the obstruction. So it can lead to progressive airway inflammation and an increased airway responsiveness to stimuli. So there are certain things that will trigger individuals to have asthma attacks or have this swelling within the airways. Symptoms include wheezing, shortness of breath, and cough. So the idea behind the medications is to remove or reduce the inflammation within the airways and also get the excess mucus out. So the asthmatic response is it ends up having an acute breathing difficulty. Again, triggers are different for everybody. It can be triggered by smoke, dust, pet dander, exercise, cold weather, even GERD, which is gastroesophageal reflux disease, common colds and flu. That's why asthmatics are particularly at risk for COVID, since COVID seems to attack the lungs pretty substantially. So long-term effects, tissue inflammation within the airways, which will lead to airway constriction and eventually lead to permanent lung damage. So the steps within an asthma or leads to an asthma attack is that the patient or person comes in contact with the trigger, whatever the trigger is. The body will release histamine within the body and other mediators. So histamine is something that is produced in our body when we have an allergic reaction to something. So think about antihistamines. That's what we use. It's a drug class we use to treat allergies. It is to prevent the release or the excess release of histamine in our body that is responding to whatever that allergen is. So then once the body releases histamine and other mediators, you then get bronchospasms and an increase of mucus production, which leads to obstructing the airways. So management levels of asthma. So levels of severity, you have intermittent, mild, moderate, and severe. So to determine the severity, they'll use pulmonary function tests. They will take a survey of what the symptoms are, and then they will also track or have the patient track the frequency in which they are using the relief medications or the rescue inhalers. Peak flow meter is used by patients to measure respiratory status. Asthma drug therapy. So quick relief medications are to be used intermittently, only when the need arises, and they're designed to provide rapid relief. Long-term persistent medications are what we would use to help prevent the asthma attacks from happening. So they are used on a regular basis, basically dosed on a daily dose. And again, they're used to prevent the asthma symptoms or attacks. So these could range from an oral medication for allergies to help keep those at bay, to daily corticosteroid inhalers. But every patient is kind of independent, and it depends on what how frequent they have asthma attacks and what their triggers are is kind of how the doctor will determine what the best course of therapy is for long-term medication. So inhalation devices, we have metered dose inhalers known as MDIs, a dry powdered inhaler, which is a DPI, and then nebulizers. So short-acting beta agonists. These are the short-acting beta agonists are the rescue medications. So albuterol is the generic name. You will see it as a brand name as ProAir, Ventolin, Proventil, Levoalbuterol is known as the generic name for Zopinex. These are medications that will stimulate the beta-2 receptors within the lungs that will then in turn relax the bronchial smooth muscle. So once we relax that, everything is so tight that the air is having a hard time getting through. And as you are opening up those airways, then you're able to have more air coming through those bronchioles. So it is recommended for albuterol that children over the age of 5, so pediatric patients, use a spacer. If patients are under the age of 5, they actually recommend that it's given with a mask. There can be some hypersensitivity reactions. So because albuterol is considered a medication that is stimulating the beta-2 receptors, it can actually increase heart rate, especially for pediatric patients. So it's something that they have to be aware of. The parents have to be aware of when they're giving the albuterol, and that they're only giving it as much as needed and not overdoing it. Corticosteroids. So these would be used for long-term or what we would do for prophylaxis for asthma. So there's different versions. Beclomethasone, which is QVAR, you have Flovent. These, because they're corticosteroids, and corticosteroids are also used as anti-inflammatories, these will inhibit the inflammatory cells and in turn suppress the immune response. So when we have an overexciting of our immune system, whether it's because we have come in contact with a virus or a bacteria, but also allergens, our immune system kind of goes on the attack, and that's where we get the excess inflammation from. So the corticosteroids are used to reduce the excess inflammation and also kind of suppress that immune response a little bit. There are side effects for these medications. Oral candidiasis, which is a fungal infection within the mouth. So anytime a patient is put on a oral inhalant or an inhalant corticosteroid, they should be advised to at least rinse out their mouth after they use it, but preferably brush their teeth. Leukotriene inhibitors. So this is a particular class of medications that are used for allergies, but these in particular for patients that suffer from asthma as a result of allergens. So Singulair, Aculate, these are two that are designed to antagonize the leukotriene receptors, which is producing the excess histamine within the body. It provides long-term control of moderate to severe asthma. Mast cell stabilizers. So cromolyn sodium, it stabilizes the mast cells and directly inhibits other inflammatory cells. So this is working on the inflammation side within the bronchial tube. So it's stabilizing all of the mast cells within the bronchioles, within the lungs, and it's preventing or inhibiting any of the other inflammatory cells from being able to produce that excess inflammation. Monoclonal antibodies. So these work by blocking immunoglobulin, which is a natural thing we produce in our body, but it is a major source of allergic asthma. So the immunoglobulin in our body produces over time. If you have a patient that is asthmatic, that is a direct result of allergens. And so this medication is designed to block the excess production of immunoglobulin, which will help reduce and prevent the major cause of allergic asthma. Xanthine derivatives, so theophylline. This drug is not only used in asthma, it's also used in patients that have emphysema. It is a phosphodiesterase inhibitor that reverses early bronchospasms and will actually improve the contractility of the fatigue diaphragm. So as patients are having a hard time breathing, they're actually fatiguing their own diaphragm, because the harder they are working to take in air and the harder they're working to expel the CO2 that's coming out, it will fatigue the diaphragm. So this medication is to help reverse those bronchospasms very early on, which will then improve the contractility of the diaphragm and help it to prevent from fatiguing. So, chronic obstructive pulmonary disease, slide 16, also known as COPD. So it's a long-term progressive condition, so that means it is not curative. So we can treat the symptoms, we can give medications that will help prolong the progression of the disease, but it's eventually going to get worse. There's no cure for it. In which the airflow is limited by an abnormal inflammatory response. So again, the disease progression is irreversible, and will progressively get worse even with treatment. Risk factors: genetic predisposition, smoking, exposure to pollution or occupational hazards, and repeated respiratory infections. Emphysema typically goes hand in hand with COPD. It is the destruction of the alveoli, or the sacs that are within the lungs. Bronchitis, so a lot of patients will get chronic bronchitis on top of this, which is an inflammation of the lining of the bronchial airways. Acute bronchitis is usually caused by a viral infection. So if you've had a cold and you go into the doctor and they tell you have bronchitis, that's acute, meaning it will eventually subside and heal itself out. Chronic bronchitis is defined as excessive production of the tracheobronchial mucus. So the excess mucus, right, excess inflammation that is continuing on, it's chronic, they continue to have it, it will come and go, but that's part of the COPD process. So drug treatments. So we use beta agonists, anticholinergics. Anticholinergics are drugs that are used to block acetylcholine, which is a neurotransmitter in our body that is responsible for smooth muscle movement. Corticosteroids, which they would use for the inflammation. They would use oxygen, physical therapy, antibiotics, expectorants. So expectorants are drugs that are used to remove the mucus from the lungs. One of the most famous medications that you probably have seen even commercials on as an expectorant is Mucinex. So it's the commercial with the little green gobbly guys that take up, shop inside the lungs, and they get all upset when the patient takes Mucinex because it gets them out. So that's what that's designed to do. So we have antitussives, which are used for dry non-productive coughs, meaning there's a dry cough, they're not coughing up any mucus. The antitussive means anti-cough. When you use an expectorant, those medications are not necessarily going to stop the coughing in general, but what they're designed to do is if there's any type of excess mucus that is stuck within the lungs, the expectorant is going to loosen that all up, so when the patient coughs, they can actually cough it out. And then obviously vaccinations. Patients with COPD, emphysema, any type of lung disease should always get a yearly flu shot, a pneumonia shot at a certain age, because that helps prevent any opportunistic infections within the lungs when they're already weak and damaged. So treatment for COPD, we have, again, the anticholinergics. So they inhibit acetylcholine as a neurotransmitter that stimulates smooth muscles in the lungs to constrict. So medications that we use that you will see very commonly are Atrovent and Spiriva. The difference between the Atrovent and the Spiriva, so Atrovent is actually a short-acting medication, and then the Spiriva is long-acting. So a short-acting with the Atrovent means they will have to use that inhaler more times throughout the day because the effect of the drug is very short-acting. Whereas with the Spiriva, it's a long-acting, so typically that dosing is every 12 hours because of the ability of the drug to stay in the system and work for a longer period of time. So LABAs, so long-acting beta agonists. So they have a similar mechanism of action to the short-acting beta agonist, which we are using for basically rescue, right? But they just don't need to be given as often. So the rescue inhalers and the rescue medications under the short-acting beta agonist, these are things that are going to be dosed very frequently, every 2 to 4 hours, 4 to 6 hours, and the reason why is they're short-acting. With the long-acting, these drugs work on the same mechanism, the exact same way, but they are designed to work over an expanded period of time, so you don't have to dose those as often. So examples of the long-actings would be formoterol, salmeterol, which is a Ceravent discs. And again, most of these have a combination of therapeutic uses, meaning they're used to treat both COPD and asthma. And we're actually going to go ahead and stop on slide 22. So if you have any questions, please feel free, call me, text me, send me an email. I'll be happy to help.